Hey everyone, it's Dr. Marcon. We are continuing with our digestive system lecture. This is part 3 on the digestive organs of the digestive system. The first organ that we're going to be talking about is the liver. The liver is the largest gland in the body and performs over 500 functions. Its main digestive function is the production of bile. Now, bile is a green alkaline liquid that is stored in the gallbladder and secreted into the duodenum, specifically the second part of the duodenum. The duodenum being, of course, the first section of the small intestine. Bile salts emulsify fats in the small intestine. What that means is they break up fatty nutrients into smaller or tinier particles so that they can be absorbed. Think of your dish detergent like Dawn that breaks up a pool of fat in a pot or a pan. And the liver also performs many other metabolic functions. For example, it absorbs or picks up glucose from nutrient-rich blood returning from the alimentary canal and stores this carbohydrate as glycogen. So again, glycogen is the stored form of glucose, and glucose is just a complex carbohydrate. So the stored form of glucose is glycogen. And this glycogen is important, especially when we are experiencing periods of starvation. Our body will tell us we need to increase our blood sugar, so we will take the stored form of glucose, which is glycogen, and release it into the blood so that our tissues can get some glucose. Other metabolic functions include processing of fats and amino acids, as well as storing certain vitamins. The liver also detoxifies many poisons and drugs in the blood and makes the blood proteins. Now, almost all of these functions are carried out by the hepatocyte. The hepatocyte is the specialized cell in the liver. And here is just an anterior view of a gross specimen of a liver. So the largest lobe of the liver is the right lobe, and then on the left is the left lobe of the liver, and it is divided into right and left with the falciform ligament here. The falciform ligament will then end in this round ligament here, also known as the ligamentum teres. And just below the inferior border of the right lobe of the liver, you can see the gallbladder. And we'll look at it in an inferior view of the liver in just the next slide. So here's a posterior inferior view of the liver. So this right here is the anterior portion. This would be posterior. So again, this larger lobe of the liver is the right, and here is the left. So we see the ligamentum teres right here. Now note, between the ligamentum teres, or the round ligament, and the gallbladder, we have this four-sided lobe right here. This is the quadrate lobe. Okay, so the quadrate lobe has four sides. It's between the round ligament has an R, and the gallbladder. So this is the quadrate lobe, as opposed to the caudate lobe. Now, the caudate lobe starts with a C. It is right next to the inferior vena cava. Inferior vena cava also has a C. So right next to the inferior vena cava, you have the caudate lobe here, okay? And also the caudate lobe is located more posteriorly compared to the quadrate lobe. Again, round ligament starts with R, quadrate lobe, four-sided, has an R. Caudate lobe has a C, inferior vena cava has a C, okay, to help you with identification. And here's just a picture again of the posterior inferior view of the liver. Again, this part being anterior, this being posterior, and this is the inferior surface. So we can see the gallbladder. If you actually get to see a gross specimen of the gallbladder, it actually really is green. And then we see the cystic duct, which will join with the common hepatic duct to form the common bile duct here. So again, here's the quadrate lobe between the round ligament, or the ligamentum teres, and the gallbladder. And here's the caudate lobe. Starts with C, next to the inferior vena cava. So also in this picture, we can see parts of our hepatic portal triad. So the portal triad is made up of the hepatic portal vein, common hepatic artery, as well as the common bile duct. So these three structures make up the portal triad or hepatic portal triad. Now, the liver contains over 1 million classical liver lobules shaped like a hexagon, or they're hexagonal in shape, meaning they are six-sided. They consist of plates of liver cells, these liver cells, again, being hepatocytes that radiate from a central vein. So hepatocytes are the functional cells of the liver. At almost every corner of the lobule is a portal triad containing 3 main vessels, which we just talked about. So we have a tributary from the common bile duct. Common bile ducts made up of the cystic duct coming from the gallbladder and the hepatic duct, which is a duct coming from the liver. Then we have a branch of the hepatic portal vein and a branch of the common hepatic artery. So these structures make up the hepatic portal triad. The bile duct carries bile away from the liver lobules, and then blood from the portal vein delivers substances from the intestines that were absorbed for processing by the hepatocytes. Now, between the plates of hepatocytes are large capillaries called liver sinusoids, which receive blood from both the portal arteriole and venule, and then carry blood inward to reach the central vein. The central vein a bunch of the central veins will form interlobular veins, and then which will then lead to the hepatic veins, which then drain to the inferior vena cava, and we'll see a picture of that in just a little bit. Within the liver, we have hepatic macrophages, also known, I believe, as Kupffer cells. Now, these Kupffer cells are specialized macrophages that are located in the liver, line the walls of the sinusoids, and also are very important in destroying pathogens, especially bacteria that might be within the liver. So there are many organelles within hepatocytes that perform very specific functions and very important functions. So for example, the rough endoplasmic reticulum is important for manufacturing the blood proteins. The smooth endoplasmic reticulum produces bile salts and also detoxifies poisons. There are peroxisomes that help also to detoxify poisons, such as alcohol. The Golgi apparatus packages secretory products. Mitochondria, the powerhouse of the cell, provide energy for liver processes. We have glycosomes, which help store sugar in the form of glycogen. And then also the liver has a great capacity for regeneration. Now this picture shows you different parts of the liver, specifically microscopic anatomy of the liver. So first in A, we see the normal lobular pattern of the liver. We know that the liver contains over 1 million classical liver lobules, and each is the size of about a sesame seed. So in B shows you one lobule, an enlarged view of one liver lobule with the central vein that drains all the blood. And then from the central vein, it will then drain to your interlobular veins, which will drain into a hepatic vein, which will then drain into the inferior vena cava, going back to the heart. So C just shows a 3D representation of a small portion of one liver lobule, showing the structure of the sinusoids here that receive blood from both the arteriole and the venule, which will drain into the central vein, going into the interlobular vein to the hepatic veins. So the arrows indicate the direction of blood flow. And here at the corner we can see structures that make up the portal triad. So we have a bile duct, a portal venule, and a portal arteriole. So the next organ that we'll talk about is the gallbladder. The gallbladder is important because it stores and concentrates bile. Bile, again, being important for emulsifying fats. The bile that is stored within the gallbladder will then expel into the duodenum. It meets up, so the cystic duct leaves the gallbladder and meets up with the common hepatic duct to form the common bile duct. And from the common bile duct, it will go into the head of the pancreas and then meet up with the main pancreatic duct to drain their secretions into the second part of the duodenum. Another enzyme that is important is cholecystokinin. This is released from enteroendocrine cells in response to fatty chyme. So again, the gallbladder just being a very important organ in the emulsification of fats. So here we see a picture of the hepatobiliary tree, and I really wish I could show you guys this in the gross lab, because this is actually really cool. So first we have our ducts coming from the liver. So we have a duct coming from the right lobe and one duct coming from the left lobe. They come together to form the common hepatic duct. When you hear the word common, just think of structures coming together in one common place, sort of like a common room in a house when you have, all the bedrooms opening up into a common room. So basically, ducts coming together form a common structure. So the right hepatic duct and the left hepatic duct come together to form the common hepatic duct. And this is draining or transferring bile from the liver. Bile is also stored within the gallbladder, and bile will leave the gallbladder via the cystic duct. So we have the cystic duct and the common hepatic duct coming together to form this common bile duct right here. The common bile duct will then meet up with the main pancreatic duct, also known as the duct of Wirsung. Again, if you discover it, you get to name it. So the main pancreatic duct meets up with the common bile duct. It will form this little dilation right here called the ampulla of Vater, and there's a sphincter that surrounds it called the hepatopancreatic sphincter. The ampulla of Vater is also known as the hepatopancreatic ampulla. So the secretions coming from the gallbladder, the liver, and the pancreas will then go through the major duodenal papilla or the papilla of Vater. Again, if you look at this grossly, this little papilla actually looks like a pimple-like structure. So all the secretions will empty out into the second part of the duodenum so that it can break down the food coming from the stomach. And the majority of digestion and absorption takes place in the small intestine. So we have the secretions from these three organs that help with the digestion, the chemical digestion of food, so that it can be absorbed along the small intestine. Speaking of the pancreas, so the next organ, which is the pancreas, has both exocrine and endocrine functions. The endocrine function of the pancreas is that it produces these two very important hormones, insulin and glucagon. Insulin coming from the beta cells of the pancreas and glucagon coming from the alpha cells. And these two hormones are very important in the metabolism as well as the regulation of blood sugar. So when we talk about diabetes, we talk about insulin going wrong or some sort of dysfunction of insulin. Insulin is an important hormone in that it takes the sugar that we absorb from our food and takes it to our tissues so that it can be used by our tissues to form ATP for energy. Glucagon is important because it basically works during periods of starvation when our blood sugar is low. So it will tell the liver, hey, release that glycogen so that we can increase blood sugar to be transported to our tissues. So both these hormones being very important in regulating blood sugar. The pancreas also has exocrine function because it does produce most enzymes that will help digest food in the small intestine. The pancreas is secondarily retroperitoneal, so we talked about this earlier in this chapter. It started off being within the peritoneum and then moved towards the dorsal part of the peritoneal cavity and became retroperitoneal, or secondarily retroperitoneal. The main duct that we talk about is the main pancreatic duct, or the duct of Wirsong. This main pancreatic duct extends the length of the pancreas and then will join the bile duct, the common bile duct, to form the hepatopancreatic ampulla, also known as the ampulla of Vader, like the ampulla of Darth Vader. So the hepatopancreatic ampulla, also known as the ampulla of Vader. Ampulla, if you hear or see the word ampulla, just think of a dilation. So basically it's a dilation because there are two ducts coming together to form this dilated structure. The main pancreatic duct and the common bile duct will then empty its contents into the duodenum, going through the major duodenal papilla, or the papilla of Vader. Now, blood supply to the pancreas, so arterial supply, is from the hepatic, splenic, as well as superior mesenteric arteries. Here we see the gross and microscopic anatomy of the pancreas. So we know that the tail of the pancreas abuts the hilum of the spleen. Okay, so here is the spleen, and we can see the splenic vessels coming from or going into the hilum of the spleen, and the tail of the pancreas is located there. Here is the body of the pancreas, and then the head of the pancreas abuts the second part of the duodenum. And this is where we have the draining of the common bile duct and the main pancreatic duct into that second part of the duodenum. And this is just showing you the different cells within the pancreas. We're not going to focus too much on that. Just know that beta cells are responsible for secreting or producing insulin, and alpha cells are important for producing glucagon. The exocrine function of the pancreas deals mainly with the acinar cells. So acinar cells make, store, and secrete pancreatic enzymes. And these enzymes, they start off as pre-versions of the enzymes, which are then activated in the duodenum. Now, the environment within the stomach going into the duodenum can be acidic. It's mostly acidic in the stomach because we have the production of hydrochloric acids, which help with the chemical breakdown of food. If there is an erosion of the mucosa within either the stomach or the duodenum, these are called ulcers. So gastric ulcers or erosions occur in the pyloric region of the stomach, the pyloric region being that funnel-shaped region towards the distal end of the stomach. And then we can have duodenal ulcers. So duodenal ulcers occur in the duodenum of the small intestine. So again, we have erosions of the linings of the walls of these structures. These are called ulcers or ulcerations. Not fun. Usually this is due to an increase in stomach acid, and it can be due to, change in diet or, a diet. Sometimes if you have too much caffeine or coffee or soda or anything acidic, this can add to the acidic environment of these structures and make you prone to ulcers. Now, peptic ulcers are also caused by a specific bacteria called Helicobacter pylori, or H. pylori. So this bacteria is actually acid resistant and can bind to gastric epithelium, which induces oversecretion of acid and inflammation. I worked in pediatric GI for 3 years, and in order to test whether or not an ulceration or a peptic ulcer was due to bacteria, we had patients do an H. pylori breath test. So we have patients breathe into an apparatus to test whether or not they are positive for the bacteria H. pylori. H. pylori is a nasty bacteria in that it can be precancerous if you have peptic ulcers due to H. pylori. So the treatment for that, of course, would be to treat the patients with antibiotics so we can get rid of this bacteria, and then the patient has to have their ulcers heal for a certain amount of time by eating a very bland diet and allowing the lining of those structures to heal. So here we see a gastric ulcer lesion in this picture, and then here is that bacteria H. pylori or Helicobacter pylori, which can cause that ulceration either within the stomach or sometimes the duodenum. Usually ulcers are accompanied by pain, and hopefully, these ulcers don't start bleeding, because if they do, it could cause a lot of pain. Other disorders of the digestive system, we have intestinal obstruction. There are two types of intestinal obstruction. We can have a mechanical obstruction or a non-mechanical obstruction. Mechanical obstructions are usually due to adhesions, tumors, or maybe foreign objects. Sometimes, especially in pediatric GI, we have children that like to swallow things like pennies or toys. I know there's a museum in Philadelphia called the Mutter Museum, where they have actual little cabinets with drawers where you pull out the drawer and they're objects that children have swallowed throughout the years. Everything from toy soldiers to jacks to coins to buttons. I mean, children will swallow anything. But if they're big enough, they can cause a mechanical obstruction within the digestive system and could cause a lot of damage. Now, non-mechanical obstruction, this is usually due to a halt in peristalsis. Peristalsis, again, being that wave-like motion that allows for the movement of food throughout the GI tract. A halt in peristalsis can be due to trauma. Also, if intestines are touched during surgery. We then run into inflammatory bowel disease. This is inflammation of the intestinal wall. And we have two specific disorders under inflammatory bowel disease, and this is Crohn's disease and ulcerative colitis. Ulcerative colitis, you will definitely see pathognomonic ulcers along the GI tract. There's a lot of inflammation. I've actually, again, had to do treatments for patients with Crohn's disease and ulcerative colitis. What I would do is I would give IV infusion of Remicade. Remicade is a medication that actually inhibits the production of certain inflammatory markers that increase inflammation due to this disease. And starting an IV on a moody teenage girl is not fun. But thankfully, she only had to come every, I think, 5 to 8 weeks. But still, starting IVs on pediatric patients, not always fun. Another disorder of the digestive system is viral hepatitis. So anything that ends in itis, inflammation of. So inflammation of the liver due to viruses. This usually causes jaundice. Jaundice is that yellowing of the skin and mucous membranes, especially in the eyes. I had a friend who actually had alcoholic hepatitis who turned, I'm not kidding, Simpsons yellow, like highlighter Simpsons yellow. That's what jaundice causes. Viral hepatitis can also cause flu-like symptoms, and there are major types of viral hepatitis. You have hepatitis A, B, C, and G. Hepatitis B being a very major type of hepatitis. Often we test for this, especially in newborns. Other disorders of the digestive system include cystic fibrosis and the pancreas. So cystic fibrosis causes pancreatic ducts to become blocked with mucus. And these clogged ducts prevent pancreatic secretions from entering the small intestine and will lead to malabsorption of fats and other nutrients. If we cannot break down fats, we will secrete it out. And our body needs fats and needs specific nutrients in order to survive. So just going over the embryonic development of the digestive system really quick, we know that the alimentary canal is formed in the 3rd week and encloses a tubular portion of the yolk sac. We have the vitelline duct. This is a landmark dividing into 3 regions. We have the foregut, the midgut, and the hindgut. So here we see parts of that. We have the foregut, the midgut, and the hindgut, which eventually will become the major structures of the digestive system. And we can start seeing these structures in the 5th week. With the digestive system in later life, middle age, usually patients are prone to gallstones and ulcers. So a typical patient who can come down with gallstones, we think of the 4 F's. A patient that is female, fat, 40, and fertile. I think there's a 5th F, but the 4 main F's are female, 40, fat, and fertile. These types of patients are at higher risk for gallstones and ulcerations. When we have an increase in the acidic environment within the stomach, it can be due to diet, it can be due to stress. Now, in old age, the activity of the digestive organs decline, fewer digestive juices and enzymes are produced, so absorption of our nutrients from our food is less efficient. Also, dehydration. Dehydration of fecal mass leads to constipation. Chronic constipation leads to diverticulosis. Diverticulosis is just an outpouching of the intestines due to constipation. Bacteria love, feces that are stuck within the bowels. When bacteria feed on, what's in the bowels, it produces gas. This gas causes an outpouching of the walls of the intestines. And this outpouching is called diverticulosis. Now, when these diverticuli become inflamed and infected, it becomes diverticulitis. So you can't have diverticulitis without diverticulosis. Now, chronic diverticulosis and diverticulitis will eventually lead to colorectal cancer. So that's why it's very important to make sure you're pooping every day. Increase fiber in your diets. Okay? So diverticulosis can lead to diverticulitis, and chronic conditions can cause colorectal cancer. And then we also have cancer of other digestive organs that can occur later in life. So that's the chapter on the digestive system.